did not want to have the discussions go in the direction of dialysis, even though her kidneys were failing. Fifth, patients consider the cost and value of treatment, particularly in light of the benefits gained. I know that's sort of not something we often talk about, we being the medical system, talk about the cost of treatment or the value of treatment, but it is a factor. The cost of some of the innovative therapies, if you've got a copay, if a drug costs $10,000 and your copay is 20%, that's a lot of money. And this is not a random example. This is an example from lung cancer therapy, where the therapy has proven benefit of extending life about 1 to 3 months, but can be very, very expensive for a family. And so they weigh whether this intervention is valuable to them. I realize in the United States we don't think like that, but we may be on the verge with our budget crisis where those kinds of conversations need to be out there and discussed. And as you think it through, it's not a bad thing, and it's okay to consider the cost and the value of the treatments. Patients also have strong emotions about treatment decisions that should be factored when you're thinking about this. Patients may feel entitled to extensive treatments. In talking to some patients, even if the likelihood is low of success, they still want these things. They feel entitled to it. They feel they've paid into Medicare, and this is what the Medicare is for, is to give them these opportunities, even though the odds of success would be low. So there's a sense of entitlement. They also may feel like there's a social contract that has to be fulfilled. I've heard this frequently from daughters of my older patients who now become my patients. I've been in practice long enough to have that. Where the daughter says, I cared for my mother and I want to be cared for in the same way. And so they feel like they made the sacrifice, they did what they needed to do for their mother, and they feel like they should have the same opportunities and the same care that's provided. These are things that we as docs don't normally consider, but they are things that families consider and patients consider in making the decision as to whether something should or should not be done in the context of life or serious illnesses. So I'm reviewing the kinds of considerations that families and patients go through as they consider these and make treatment decisions. Page 10, or slide 10. Patients considering major treatment decisions are influenced by their families. Does that come as a surprise? It shouldn't. And families' emotions often are part of the decision. Is the family ready to accept the patient's decline? Does the family have unfinished business? Unfinished business with the patient, and so they want the patient to have every chance to extend their life, even though there may be difference of opinion about that? Are there important family milestones on the horizon? This is not an unusual circumstance that we face in terms of childbirth and marriages. Is this a reason to accept an intervention that would prolong life, albeit briefly, to meet that milestone? That's a perfectly reasonable reason to go forward with an intervention. Patients also have a sense when they consider these things of whether they're an optimistic or hopeful type. I have had conversations with patients who have extensive cancer and their prognosis is grim, but they've always lived life with optimism and hope, and by God, they're going to be in that 3%. So that's something to consider. Is that the reason why they're choosing intervention? It's a reasonable consideration. And so you want to have an idea of where do you stand on the optimism and hope continuum. Patients have unfinished business of their own, and also with their family. And this is not an unusual reason why I hear why people want certain things done for a period of time, is to have time to, so they'll say to me, if I have to go, I need time to do X, to get ready. And it's time with the family to talk about their lives in their past, to give and get forgiveness, to say I love you and I feel loved. I mean, these are all important conversations that take time to do. So often they'll make a decision based on needing that time. And that's a pretty profound and important consideration. So if they need time to do that, then your doc, I would work hard to try to get you that time, potentially to do that kind of work. The last reason is patients may choose to submit to treatment or refuse certain therapies out of religious conviction. Jehovah's Witness, for example, would refuse to accept blood products, even if they were hemorrhaging to death. That's a religious conviction. Some of my Orthodox Jewish patients almost always will want to have feeding tubes well beyond the time I would recommend continuing it. That comes from religious conviction. These are beliefs that obviously we respect and would seek to honor. For each patient, these considerations have unique weighting. Not every consideration carries the same weight for every patient. So this is why, as you prepare an advance directive, consider which of these influences are most important to you. The idea is to use your advance directive to individualize treatment if you're unable to say so, what your wishes are. It will simplify decision making for those that you ask if you give them that kind of guidance. So on slide 11 are some of the typical treatments to consider. I won't talk about all of them. Blood transfusions are a common one. Transfusion therapy typically requires a trip to the outpatient infusion center. And if it's done infrequently, the type and cross, that is the matching of the blood, can be done pretty quickly, and the infusion can be done without a lot of hassle. But I've had some patients, and Dr. Green probably has a few of these patients as well, where they have a chronic blood problem where their body doesn't make enough red blood cells, and over a period of years, they get 10, 20, 30 transfusions of red blood cells. Each time that happens, the body develops antibodies. The body doesn't accept these red blood cells as easily as the first transfusion. And so the effect and the durability of the transfusion decreases. So it used to be 30 days between transfusions, and now it's 15, and then a week. And they become harder and harder to find the blood that matches. And so the time spent and the hassle involved increases. So I've had some patients who will decide that they no longer seek to have these blood transfusions. And that's how they would weigh it, is the convenience versus the durability of benefit. The other issue to talk about is the CPR issue. The success of CPR depends on a number of factors.